So welcome our Facebook viewers. Thank you very much for joining us. And yeah, you can continue, Richard.
Thank you, Grace Nzula, the moderator of choice, for the video that you have shown us that reminds us of our colleague and friend, Kevin Adibo, who passed on several weeks ago. We remembered him. We will always remember him for the work he was doing for the HR community and several stakeholders. Thank you very much. Those who have come today to understand diabetes, today we are going to separate the facts and the myths that surround diabetes. And you're privileged to be with Professor Nancy Kunyiha, who is a clinical professor of medicine. The last time we were together, she was doctor. Now she's made good progress, daktari, now professor. Congratulations. We can celebrate. That's a promotion. Watu wa HR ni watu wa celebrate watu wakipata cheo. They're the ones who are in charge of promoting people. Nancy, thank you very much. You're welcome to help us understand what is diabetes. What are the facts? What are the myths? This is the co-host, Richard J. Magoma. Karibu, Nancy. Let us celebrate Nancy as she comes online.
Thank you, thank you. And without further ado, I'll share my screen. I want to thank you for this opportunity to be able to just speak about diabetes, which is what we do every day. And I just want to go to our slideshow. And I spent most of my life practicing endocrinology. I hope I'm clear and can be heard.
Yes, you're very clear.
Great. And in the next few minutes, I'm going to try and put together things I feel are the key myths and facts about diabetes, and I hope we can have a constructive conversation at the end of it. So November is World Diabetes Month, and this year's theme was Know Your Risk and Know Your Response. And so today I'm going to take us through what is known as facts about diabetes and the myths. And why this is important to discuss is because I think this frames our perception of diabetes. It frames our honesty about it. It frames whether we stigmatize diabetes or not. And it also frames our health-seeking behaviors and our success in managing diabetes well. So diabetes is going to be on the facts, and diabetes is not is on the myths. So diabetes is one of the epidemics of the 21st century. So 463 million people are living with diabetes in 2019. And this number is going to rise, is anticipated to rise to 700 million. And why I put up this slide is that if we look at across the continents, Africa, sadly, is going to have the highest rise of diabetes at 143%. So we are going to rise from 19 million people in 2019. We're already in 2023, and this number is projected to increase to 47 million by 2045. So as much as it's a global epidemic, the numbers are going to be felt more in Africa, and that burden is increasing. 1 in 10 adults between 20 to 79 have diabetes. That's around 537 million people across the world. 1 in 2 are undiagnosed. So these are important facts. So of all of us listening here, if we are 100 of us and 100 of us have diabetes, 50% of us don't know that we have it. 1 in 9 people have what we call pre-diabetes, which means either your morning sugars or sugar after a meal is elevated. And 1 in 6 live births now are affected by hyperglycemia in pregnancy, what we call gestational diabetes. And I'll talk a bit about these different areas. 6.7 million deaths are attributed to diabetes. So diabetes portends risk and certain complications that cause death and can be attributable to diabetes. So these numbers of persons living with diabetes is higher in the urban area. And if you look at this little graph, and these are IDF statistics in 2021, the numbers are increasing more in the urban compared to the rural setting. So what is diabetes? Diabetes is actually defined as a chronic condition, as something we live in, and we'll talk about the myths around that. And it is high blood glucose in the body, which most of us call blood sugar. And glucose comes from our food, and different foods have different types of sugar and also different amounts of sugar. And in normal physiology, when everything is okay, the bloodstream usually transports glucose to all the cells in the body. And so the body is always working to keep our sugars normal. So when glucose levels increase, usually there is a problem with how much insulin we have. So diabetes simply is actually just having too much blood glucose in your bloodstream. So diabetes is a defect in insulin secretion. So this graph here, this picture shows us the pancreas, which is the yellow one, and it's a little organ which is in the middle of our abdomen. And this is responsible actually for producing insulin with a cell called the beta cell. And so when we have high sugars, we should produce enough insulin, like if you drink a Coke. And this insulin allows the body and stimulates the body to use that glucose, and it's moved from the blood to different organs. So when there's an abnormality in this function of the pancreas, your sugars become abnormally elevated. The liver is also a very important organ in managing blood glucose, because that's where it is stored. And when we have excess blood glucose, the body should sense that, and it's stored as glycogen. And this glycogen, once it is kept there, when we are hungry or we don't have enough sugar, the liver breaks down glycogen into glucose. So there's a delicate balance constantly happening in our normal physiology and the way God made us to keep our sugars normal. So another fact is that as much as diabetes seems very simple, it is a complex condition. And that's why many of us spend our lives every day trying to assist and help people prevent diabetes and also manage diabetes. And I'm going to go through this pictogram just to explain how complex diabetes is. So we talked about the pancreas, which has the beta cell that produces insulin. There's another cell called the alpha cell, which produces glucagon that prevents your sugars from going down. Then once we eat food, your intestine is actually responsible for producing two significant hormones that actually stimulate and cause the utilization of glucose. So it starts actually as we start eating. The fat cells here, which are in yellow, whenever we have excessive weight, we have something called lipolysis. So fat cells can break down material, and that material actually blocks the function of insulin. So fat cells are not innocent. The kidney, whenever we have high sugars in the body, the kidney also secretes glucose, and it is involved in glucose reabsorption. So the kidney also plays a part in the regulation of your blood sugars. And then we have muscles, and that's why we are told to be active. So when we walk or are moving around, there are certain receptors in your muscles that actually use glucose. The brain is also involved. So when we are working, that's why we need energy. And you find children in school or teens that are reading, eat more, a bit more when you're studying a lot. So the brain utilizes glucose. We've talked about the liver, and finally the pancreas. So I put this picture here for us to see that when we have a high sugar, it's not just about one organ or just about the number that you see. So as much as diabetes is complex, it's easy to diagnose. So I want us to remember simple numbers. If you have a fasting sugar, that means you wake up in the morning, you've not eaten overnight, that is between 4 to 6, that's normal. The normal is 4 to 5.6, but I like 4 to 6 for reminder. After meals, 2 hours after meals, your sugar should be 4 to 7.8. If your sugars are above that, we call it pre-diabetes. And pre-diabetes is a category where your sugars don't fall into diabetes, but they're not normal. So 6 to 7.1, as you can see there, and after meals, 7.8 to 11.1. And finally, a diagnosis of diabetes is a sugar of over 7.1 in the morning when you've not eaten, and after meals, if you have a sugar of over 11.1. The important thing to know, if any of us gets a high sugar, you usually need 2 sugars to confirm that you have diabetes, or if you have symptoms of diabetes, which are usually excessive thirst or weight loss, and a high sugar, then you can make a diagnosis of diabetes. Down there, I've put something called the HbA1c. It's a test that measures a 3-month average of blood sugars. And if it's below 5.7, it's normal. Anything between 5.8 and 6.4 is pre-diabetes. And if you have a HbA1c of over 6.5%, then your likelihood of diabetes is high. So diabetes is classified into different types. So there are different types of diabetes, and that's a fact. So many years ago, we used to talk about insulin-dependent and non-insulin dependent. And we are always learning, and science is changing, and we have more and more testing being done. So I'm going to just simply put down the different types of diabetes so that when we are also reading articles on Facebook or different things, and people are talking about reversal and remission, we need to understand that there are different types. And sometimes the material we are reading is about certain types of diabetes. So type 1 diabetes occurs in younger children usually, and it can occur even in the neonates, even at a few months. And usually type 1 diabetes occurs suddenly, and the pancreatic cells we talked about are knocked off by a single event. When you look at studies, it's not fully known, is this viral? There seems to be a genetic factor to it. And there are lots of studies going about the autoimmunity associated with type 1 diabetes. And there are certain tests now that you can do to kind of further classify how type 1 diabetes behaves. So what we must all know about type 1 diabetes is that the pancreas is fully knocked off. So people with type 1 diabetes use insulin for therapy because you can't live without insulin. Now, type 2 diabetes usually occurs a little later, and it's associated with obesity and overweight. And what is different about type 1 and type 2 is in type 2, you have some residual function of the pancreas. So those individuals can sometimes use tablets. Sometimes you can actually go into remission if you lose weight. They can use diet. And we have some people with type 2, as time goes on, who use insulin and tablets, and some who use insulin as predominant treatment. Then we have gestational diabetes, which is diabetes in pregnancy. And this is becoming more common as women increase in weight before pregnancies, and is affecting more and more women, I find, in clinical practice now. And I'll just share 1 or 2 things about it later. And then there are other types called maturity onset diabetes of the young. There's another one called LADI. So there are actually different types of diabetes. And when we see healthcare practitioners, or if you're ever diagnosed or a family member, it's good to have a discussion about the type of diabetes you have and what it means for therapy. So the journey to diabetes, especially type 2, happens slowly. So it doesn't happen suddenly. So if you see in blue here, you have a curve where the insulin goes up for a while and then comes down. So your beta cell is producing, we call it hyperinsulinemia. And as the insulin levels go down, the sugars in the green here go up. And then you can see in red here what we call insulin resistance. Remember, we said when we have weight, the fat cells produce certain substances that actually block insulin function. And these are a continuum. So they're happening in this individual or in the person, which is something you can't see. But what happens is that you have pre-diabetes first. Remember, we talked about the level that is not overt diabetes. And this pre-diabetes can go on for even 2 to 4 years before you come to a doctor with high sugars of over 11.1, or in the morning when we talked about sugars of over 7. So diabetes risk is known. So what are the risk factors? Excessive weight is a risk factor. Not everyone who is obese will get diabetes, but excessive body weight is a risk factor. Sedentary lifestyles in COVID, when our kids were sitting at televisions and not going out, we had an increase in weight and size of a lot of individuals. Pre-diabetes, so if you have pre-diabetes, then you can go into overt diabetes. And then the intrauterine environment, and there are a lot of studies going on about that, is like if my mother had diabetes, what happens to the fetus then? If a mother is obese, what happens to the fetus that is growing? And then we have the metabolic syndrome. And the metabolic syndrome is constituted by a high weight or an excessive weight, which is traditionally used as BMI, a waist circumference that is larger than it should be, and there are cutoffs for men and women. And then I'm having abnormal blood glucose. So many times these occur together. And individuals have high cholesterol at this time, and the question that always comes up is hypertension a part of this? And you find that these constitute the metabolic syndrome. And usually when a person has one of them, something else is found along the way. Then we have the non-modifiable. And the non-modifiable are the things we can't do anything about. So ethnicity is one. So we know there are certain groups and populations that have more diabetes than others. If you have a family history of type 2 diabetes, like I have a strong family history, so if I look across my parents and relatives, my family has a strong history of type 2. So that makes me at risk, and I can't do anything about that. Age, as we grow older, because the pancreas is also aging. A history of gestational diabetes. So any woman who has had diabetes in pregnancy is at a higher risk of diabetes in the future years and must continue testing her sugars even after that baby. And then we have something called PCOS, which is an ovarian syndrome, which is quite common now, I find, with women being overweight. You get a little beard, and when you do a picture of the ovaries, it's got multiple cysts. So that is also associated with diabetes and insulin resistance. So what's the elephant in the room? Diabetes is related to obesity. And these are WHO statistics in 2022. 1 in 5 adults and 1 in 10 children are projected to be obese in a very short while. You can see that's 2025. And this was data in 2022. Africa, interestingly, is home to 24% of the world's largest overweight population below the age of 5. And what are the obesity drivers for us as a continent? It's energy-dense foods, so the foods we eat, a lot of deep fried, a lot of, mandazi, a lot of the way we eat generally. Sedentary lifestyles, lack of physical activity, and this, of course, is more in the urban setting. And I want to highlight this is lack of policies, because our health policies and food sector policies all affect all of us. Urban planning. So if we don't have places for children to play and run, then they are at a higher risk of diabetes as they grow up. So a recent democratic health survey here in Kenya found 50% of women between 20 to 49 who are educated were obese or overweight compared to the uneducated. So women who have a high education rate seem to be more overweight. 43% of women who lived in urban areas were obese compared to 39%. And the percentage of women who fall within the obese category increased from 38% to 45%. So this is a growing problem. I know we are embracing plus sizes and there's a lot of conversations around that. But from a health point of view, we need to rethink this whole conversation. So obesity is a chronic disease. And obesity is not always from overeating. So we do know that there are some abnormalities, what we call leptin abnormalities in the brain, that cause certain people not to feel as full and which affect your entire metabolism. So we find people who struggle with obesity and it's not that they eat that much. So there's more and more information on that now. Obesity is not an innocent bystander. So when we are overweight or obese, our risk of arthritis and gout is more. We have a higher risk of diabetes and high cholesterol. We have more risk of liver disease, of gallbladder disease. You know, gallstones are more in obese individuals. We have sleep apnea, so we don't sleep as well because you're snoring. And then it makes you sleepy during the day, and that reduces productivity. And then obesity also affects our fertility rates. And we're having more and more women struggling with fertility as our weight goes up as a society and a continent. And then we have stroke, and we have the risk of cancers like colon cancers. All those are, you have a higher risk because of obesity. So diabetes, if you have the genetics, remember we talked about that, can be triggered by diet. So if you're eating excessive refined foods, sugars, you know, very sugary juices that we are buying in packets, chocolates, sweets, those trigger diabetes. What is the relationship with alcohol? Kenyans are farting a lot and we are drinking a lot. There's something called NAFLD, which is non-alcoholic fatty liver disease. So now we know that metabolic disease can cause fatty liver. And when we have fatty liver and then you add on alcohol, the net result is we are going to see an earlier epidemic. In fact, the gastroenterologists are calling it epidemics of liver disease and liver cirrhosis. So diabetes can cause complications. It is related to complications. And diabetes is painless. So because it is painless, we usually are not as anxious about it as if we had, you know, pain in your body somewhere. And that's what is scary about diabetes is that we ignore it, but the long-term consequences can be really catastrophic. So we have two types of complications, what we call microvascular, and those can affect your eyes, they can affect the kidney, and they can affect your feet where you get abnormalities in sensation. And then we have macrovascular complications that are related to stroke, your heart attacks, and what we call peripheral arterial disease, which a lot of us know can lead to amputation. So the other fact is when diabetes is well controlled, you reduce complications. So that's a well-known fact, especially microvascular. So you can avoid complications to the eye like bleeding, you can avoid problems with feet, and I know this is a gross picture, but it's a reality that we face. And then you can reduce also your macrovascular complications. So diabetes is manageable, that's a fact. And there's a lot of hope for persons living with diabetes. And whenever I'm talking to patients the first time, because we are so scared of complications, is that there is a capacity to live out the years that God has given you if you have diabetes, if it is well managed. So physical activity is part and parcel of management of diabetes, as is diet. So there's no need of taking medications if you're eating badly. So these go hand in hand. And then insulin and tablets are another modality of treatment. So what is physical activity? You don't have to join a gym. Physical activity could be in the garden, it could be skipping, it could be walking, it could be cycling. And I think the most enduring one is walking because it doesn't cost money and it's something you can do even to your old age. So when we talk about food, the foods that people with diabetes, you can actually eat most of the foods with diabetes as long as they don't have sugar. So all these foods can be eaten by people with diabetes, okay? So you can do your legumes, you can do your meats, you can do proteins of different kinds, your fresh fruits and vegetables. But what I want to say about fresh fruits is remember, fruits have fructose, and fructose is a sugar. So the way we traditionally eat a big meal and then add on watermelon and lots of slices of fruit and bananas will spike a sugar for someone with diabetes. So maybe we need to space out our intake of fruit and take it probably between meals. And for persons with diabetes, not to use huge amounts of fruit as a pure substitute for food. So we have insulin devices which are available in our country. Insulin comes as vials. We have pens here on the left-hand corner. And now we have what we call CGMs, continuous glucose monitoring. And these are still a bit expensive for us, about 16,500 for about 2 weeks. But the insulin pumps for type 1 diabetes are changing the whole management of diabetes. And these ones are put on your body and they deliver insulin. And the more recent ones have sensors so that when your sugars come down, they can cut off the supply of insulin. And they are going more and more towards what is the artificial pancreas. As a country, we are working towards how do we get these monitoring and devices in the country without heavy taxation and affordable for the continent of Africa. So I know a lot of you have heard about bariatric surgery. So diabetes that is related with obesity is reversible by bariatric surgery. And this is offered at certain cutoffs of obesity. And on the left panel here is what we call the gastric balloon. So it actually just reduces your intake and makes you feel full. And this can be used for 6 months to 12 months. This other one is a gastric band, which reduces the stomach size. You can see that as you come in. And then we have bypass procedures where you actually reduce the actual amount of the stomach. And finally, the gastric sleeve, which is a more radical kind of surgery where you actually cut off a large part of the stomach. And all these can be done and they're available. But when you are seeking these, they have to go hand in hand with diet modification, with counseling and advice, because some of these, like the surgical ones that are more invasive, sometimes come with nutrient deficiency. So you need supplements to keep your nutrients good. So I want to just talk about diabetes remission, because I think there's lots of conversations around this. So when you think about diabetes like type 1, it's not curable. But when you have type 2 diabetes, we call remission a state in which usually the individuals have lost weight, whether it's through surgery or diet, and you're able to maintain normal sugars with a HbA1c of less than 6% on diet. That is what we call remission. Now, remember, anyone with diabetes, if your pancreas is not producing enough insulin, when you put the weight back on, the potential for diabetes remains. So usually this terminology is used in type 2 diabetes, and diet and activity remain the mainstay of therapy. So I had one slide of myths as I kind of come to the end of my talk so that we can have a conversation around some of these things we've talked about. So diabetes, the myth is that it is curable, but it is preventable from what we've said. So managing our weight, even if you have a risk factor, can prevent diabetes. People can go into remission by cutting weight and by eating the right foods and reducing the amount of carbohydrate and refined sugars in their meals. But type 1 diabetes requires insulin because your pancreas is not producing insulin. Sugar causes diabetes, that's a myth. We've seen that there are multiple factors that cause diabetes, so sugar is just one of them. So people who eat sugar don't necessarily get diabetes. The other myth, if no one in my family has it, I can't get it. Anyone can get diabetes. Okay, some families have it more, but many times we see individuals asking, no one in my family has it, why did I get diabetes? There's another myth that everyone with diabetes will get complications. That is not true. If you manage diabetes well, you will live a full and healthy and productive life. The other myth is everyone who's overweight will get diabetes. That's a myth. So you can have diabetes when you're slim and trim also, and especially type 1 diabetes. The other myth is that you become dependent on insulin once you start it. So go back to what we talked about. If the pancreas is not producing insulin and you give insulin, you don't become dependent. It's just one of the therapies for diabetes. People with diabetes can't eat fruits. We said that's a myth. They can eat fruit, just eat the right amounts and at the right times. And finally, in Eldoret, there was a sauna curing diabetes, I think 2 days ago. I think that's a myth, and we need to debunk these myths. So I think my talk would not be complete to say that it's important that our blood pressures are checked and managed because they also damage your blood vessels. And our target is below 130/80. And our cholesterols must be checked and also managed for people who are over 40. And if they're high, please treat your cholesterol because these clog the blood vessels and the end result is what we see, myocardial infarctions and sudden deaths. So finally, what are the pillars to managing diabetes? Sugar control, we have blood pressure management, cholesterol management, and using now therapies, which are many, which would be the subject of a talk for another time, that actually prevent kidney damage and protect the heart. So who takes care of diabetes? Just the teams that do. There are us who are the physicians. The nurses, nurse educators play a very big part in educating patients. So when your doctor tells you, please see a nurse educator, that's as valuable as seeing us as specialists. Anyone living with diabetes must see a foot doctor at least once a year, or a doctor like me. I look at my patients' feet just to make sure you don't get ulcers or you don't have blisters that you can't feel or you're not developing neuropathy. Counselors and social workers are important because this condition affects our pockets, it affects our mental health. And to cope well with these conditions, even in the workplaces, many times we need support. And other professionals like ophthalmologists and dentists. So diabetes is associated with cancer, and I just put this up because cancer is a leading cause of mortality in our country, and we need to think about screening. So what do we screen for? Diabetes. If you're over 40, check your sugars once a year. If you've had gestational diabetes, like we said, you must check your sugars after delivery, 6 weeks after and annually. Hypertension, I hope all of us have checked our blood pressures this year and cholesterols. And if you haven't, please get them done. For women, our mammograms every 2 years from 40 years and earlier if higher risk. And for cervical cancer, let's do our pap smears, and for men, our PSAs. So I'll close with saying, know your risk, debunk the myths, know your response, and embrace the facts. Thank you very much.
Thank you very much, Professor Nancy Kunyiha, for that rapid presentation on how we should understand diabetes. There's a gentleman, I think, who is asking you go back to the myth. I don't know why he wants us to go there. Why do you want us to go to the myths? Something you didn't understand?
He could ask the question. I think now we're at Q&A.
Okay. Go back to the myths briefly. That is
Okay.
Alacano, Jaso.
Okay. And he's welcome to ask the question or write it.
You can write the question.
Richard, you can read it out for me in the meantime. Because I need to now go through the, okay.
Ah, there you are.
Yep.
Yeah, I don't know whether he wanted you to repeat.
Or maybe he wanted to look at it, or yeah.
Okay. All right. All right. Thank you very much. We can appreciate Professor for that informative presentation that she has given. Now we are more informed. Let me start off. Why should a non-diabetes be interested with diabetes first?
A known person. What do you mean non?
No,
like
somebody who's not suffering from diabetes. Because
yes,
somebody will say, why should I listen to diabetes talk and I'm not diabetic? But what is the essence of a person who does not have diabetes listen to a diabetic talk?
Because we all have a pancreas, and because our pancreas can malfunction, and because and I think the fact that we have a pancreas makes us all at risk. Okay. And the fact that we are all eating food that has sugar, and we have the potential to eat and be overweight gives us a risk. So I think diabetes should be the interest of everyone, because you don't know when that whole metabolic shift can happen.
All right, thank you, Professor. There is George Muga who is asking, why Africa? Why should we have that shocking increase of diabetes in Africa? Is there something we are doing wrong?
Yeah, I think one of the things was the earlier presumption many years ago, even when I started practicing, was that there's no diabetes in Africa. Okay, so many years ago, it was just assumed Africans are active, they're running around, they're in shambas. So we are urbanizing very fast, faster than we think. So if you go up country now, kids are drinking soda. KFCs are everywhere, isn't it? Chips, we are eating bread. So we have urbanized very quickly. And then we have not studied our genetics as much. So when we have shifted from rural active lifestyles to sedentary ones, it's just blown up. So I think there's a genetic component to it. There's the makeup of how we are as an African, is it species, or that is not fully studied. But I think the rapid urbanization has played a very large part in it, and we have not been ready. So even our policies and our just decision making around it we are just not ready for this whole epidemic. So even our response is not as good. We are not screening as well. We don't have structures in place even to, diagnose all the people with diabetes?
Great. In other words, you're saying that the ignorance of diabetes and the economic reasons surrounding it, and also lack of financial muscle to understand what is diabetes, which we are doing right now through Atara Solutions. Then there is Emma Wanzenga, who is asking what causes high fast blood sugar and rapid blood sugar. What causes this?
Okay. Is that Richard, is she asking high fasting blood glucose or high?
Yes. Yeah, what causes high fasting blood sugar and the normal rapid blood sugar? How can they be controlled? How can we control fasting blood sugar?
So fasting blood sugar is an interesting one. So remember, we talked initially about when you're in this pre-diabetes phase, there's a part where the pancreas produces a lot of insulin, which we call it hyperinsulinemia. And fasting blood glucose is more challenging because remember, the liver breaks down glycogen to give you sugar. And then you have in the pancreas, which is not functioning so well, two cells, alpha cell and beta cell. And those become imbalanced in diabetes. So when you have that abnormal function, in the morning, your body should give you enough glucose because you haven't eaten all night, but it shouldn't be too much for it to come down. So that abnormality is actually what makes diabetes. You have an abnormal functioning of those cells. What can you do about it? If you have diabetes, eat less late at night. So you know the habit Kenyans have of eating dinner at 9 o'clock. I think we need to start learning to eat earlier if we can.
We eat like in the evening.
Exactly. So like now some of us are going to have dinner after this show at 9. And what happens? You're just going to rest. You eat your big ugali and a lot of carbohydrate. And what's the net result? We put on weight and your sugars are higher. So actually eating earlier and less carbs earlier actually improves your fasting blood glucose.
Thank you. As a rider to that, how do you manage pre-diabetes before it becomes diabetes?
So pre-diabetes is great because it's completely reversible. And that's why we should not be afraid of checking our sugars frequently and during health checks and all that. And the management of pre-diabetes is actually to stop sugars and refined sugars. You know, we talked about refined sugars. You know, even things like the Del Monte juices, sodas, take them out of your diet. Less carbohydrate intake, and that means like if you're eating 3 chapos, maybe you come down to 1 or a half. And many people with pre-diabetes will actually reverse to normal sugars by cutting, I find usually about 4 to 5 kilos if you're overweight, and cutting your sugars. So there's a lot of hope when you find pre-diabetes early, actually. That's the best time to get diagnosed with pre-diabetes. So don't be afraid to test those sugars. It's reversible at that point.
Thank you, Professor Nancy. There is Olga Nyanga, who is asking, now that you've mentioned that weight is a major contributor towards the prevalence of diabetes, can you take an injection so that you lose weight?
That's now it's very interesting. She's raised that because there's now the big buzz. Remember, we talked about the intestine and two hormones that actually help. They are called GIP and GLP, glucagon-like peptide. And now there are injections that are being given for obesity and overweight. They were initially for treatment of diabetes that can cause up to 10% of your weight loss. So one of them is called semaglutide, and it comes as Ozempic. You'll see it. There's a big buzz about it. Very expensive, but it's being used in the West where they have a lot of obesity. Yes, that can be used, but the question becomes, what happens if you stopped it? Okay, and if I'm using $1,000 for an injection and I can eat less to prevent obesity and overweight, why not? So these injections may be good when you have morbid obesity and even the procedures and are not able to move. But once you lose weight, it still comes back to diet for majority of the people. So an injection might be a quick fix. It's an expensive fix with the current dollar rate. But yes, there are some injections that are used for weight loss.
Now that we're talking about weights, and then we spoke about body mass index, what is the ideal BMI?
Okay, so first let me put a caveat to that, because there's a question now about, is the traditional 20 to 24 BMI that is there in the textbooks the same for Africans? Is it the same for Caucasians? We know the Japanese. So now different continents are actually starting to change their BMI cutoffs. So like the Japanese who are smaller, should they have the same cutoff as a Western population? So 20 to 24 is the traditional normal BMI that we use, but now there's a lot being used on waist circumference, okay? And there are thoughts as to what should the BMI be like for the African population? Should we bring it down? And are we missing people when we put BMIs a certain way? Or should it be higher? Do we have bigger populations? So the jury is still out there, but we use the 20 to 24 cutoff right now. And BMI is a function of weight and height, yeah? Yeah.
There is a very interesting question from Lily Mwasho.
Yeah.
Looks like she wants the sons, the daughters, the husbands, the boyfriend around her should be able to know whether diabetes affects reproductive functions in a man.
In a man. So I think how diabetes, and that's a great question, because what we see in the practice of endocrine is, for women, we've talked about it. We have this PCOS, polycystic ovarian syndrome. We have more infertility when we are overweight. But for men, remember, we have a higher conversion, yeah, of testosterone to estrogen in the liver when we are obese. And there are men who we see, when they cut weight, their testosterone levels go up and their sexual function improves. So that's a talk for another day. But yes, it does affect obesity, even in males, will affect fertility and testosterone levels and libido.
Okay, there you have it, Lady Marsha. Modoni wants to know, should you go to medicine first and then, or should you exercise, eat well? So which one should come first?
Okay,
medication?
That's a great question. I think the ideal, Richard, is if we didn't get diabetes. So I think always it's, can we prevent? Can we screen? Can we keep our weight down so we don't have to get there for a majority? I'm not talking about type 1 because people don't do anything wrong to get type 1 diabetes. But let me put it this way. If you're screened and found to have pre-diabetes or diabetes with sugars that are not extremely high, diet can reverse this, can take you into remission, okay? Many times where I sit, we diagnose sugars in Kenyans which are 35. So when you come to my clinic with a sugar of 35, do I tell you to go home for 3 months and just do diet? So the challenge I find in our context is very late diagnosis. And at that point, people have what we call glucotoxicity, and they're sick and they're symptomatic. Those people need therapy. Diet goes hand in hand with that. So I would say you individualize and you contextualize it to the person that is in front of you. And there's no one size that fits them all, but diet goes across the whole spectrum.
Fantastic. Now let's talk about diagnosis. I am in SHADS. What signs should I observe so that I can be able to know, oh, these things are not right?
Okay.
I am not in the capital city to go to counselors like Monica, who is on call here. I can go to a professional like you to understand that I have diabetes. I'm in SHADS completely, where the ratio of specialists is totally reduced to the entire population.
Agreed. So what you know what would be great is if our taxes were just used for every person in Kenya just gets a sugar done who is maybe over 30. And that's what they've tried in places like India once a year. So if you could just get that sugar done, it gives you at least some idea where you fall. Okay. 2 is symptoms. By the time you have symptoms, your sugar is already over 12 to 13. And remember that spectrum we saw? The sugars have been high for over 2 years by the time you get symptoms. So the idea is to actually pick diabetes and abnormalities in blood glucose before you become symptomatic. But when you're symptomatic, you urinate a bit more than usual, you feel more thirsty than usual, and you lose weight, which is unplanned weight loss. And people feel hungry, but because the blood glucose is just sitting in the bloodstream, you have no energy. So you have a high sugar, but it's not being used in the bloodstream. So excessive thirst, excessive urination, weight loss, and sometimes you get blurring of vision, and just a fatigue and general tiredness are the symptoms or classical symptoms of diabetes.
Great. And there is a question here by CHRP. Sarah Maina, she wants to know whether stress and depression can cause diabetes. Of course, I know she wants to know, can stress aggravate diabetes?
Yeah.
Prof, that is the phrasing.
And she asks a very good question, because what does stress do to our bodies? We produce cortisol. And cortisol is a hormone that actually raises blood glucose. So many people will come, I find, to practice and say, I got diabetes when my husband died. Or I got diabetes when I had this, catastrophic life event. So maybe you had the genetics to it, and then something happened. And during that extremely stressful period, that's when it comes up. So the stress does not cause it directly, because there are many Kenyans are stressed. Everyone doesn't have diabetes, yeah? But stress can be a trigger, or it provides an environment because of those cortisol and certain hormones that are increased during the state of stress that can trigger and worsen a predisposition to diabetes. Depression usually can cause abnormalities also in cortisol. And when you have very bad depression, cortisol also goes up, and you can get some abnormalities in blood glucose, but it's not that everyone who is depressed gets diabetes, if that makes sense. Yeah.
Okay, thank you. There is Karo Muhonja Mgali. Thank you, Professor, for the great presentation. What are the symptoms that one is blood sugar is high? Second question, strength training. Can strength training help in management of diabetes? The third question is there a relationship between diabetes, Alzheimer's? I've read somewhere that Alzheimer's is third type. I don't know, how true is that? Is it a myth or a fact?
Okay. I think we talked about the symptoms already, so I won't repeat those. Strength training is great because whenever you're using your muscles, remember we said you have certain receptors in your muscles, that first picture I showed, that actually utilize glucose. So any activity that is increasing muscle utilization of glucose will actually reduce glucose in the blood. So strength training is great, and especially as we grow older, to tone up the muscle. So the more muscle you have, the better the utilization of blood glucose. Alzheimer's and most dementias are becoming part of NCD. I think the question is diabetes the cause of dementia, or do many people with dementia have diabetes? Cause and effect. So it is known, though, that persons with it's not, I wouldn't call it a direct causality, because the rates of dementia are also going up, globally? And there are many factors associated with that. And it's remember, dementia is a neurological condition, and I think we could talk about that for a very long time. I just want to say that dementia, we see it in persons with diabetes more. And remember, we talked about diabetes affecting blood vessels. Remember that. So diabetes actually inflames blood vessels. So poor control of blood glucose can increase your risk of dementia. Let me put it like that. Rather than a direct, not everyone with diabetes will have dementia. I don't want anyone living here with that fear. There's also there's a myth that if you take cholesterol medicines, you'll get dementia. Again, that is another whole conversation that people read about. And again, not a true causality effect, because you'll get risks of heart attacks if you don't manage your cholesterol as well and have diabetes. So I'm seeing some questions coming up. Nerve damage by diabetes, can it be reversed? I think if we pick it up early, yes. And because remember, nerve damage is something, to reverse that, it takes a bit of time for nerves to regenerate. So I have seen patients with very bad, what we call neuropathy, improve over 1 to 2 years. So the idea is to prevent them happening. There was a question, Richard, there, can diet reverse diabetes? I think if the person was there earlier, if you're obese and overweight and lose 20 to 25% of that weight, your sugars will come back to normal. If you're overweight and reduce your weight, it helps the sugars. So I like the term remission, because if you've got diabetes, remember there's an inherent capacity to also have abnormal blood sugars if you revert back to a higher body weight.
Thank you, Professor Nancy. I remember you, Nancy, Monica, who is here, and the other lady saying that you should be able to look at your numbers. How do you select a good glucometer? Because there are some glucometer which are completely insane. There are some which are accurate. How do you decide that a particular glucometer is a good deal?
You're asking political questions. I don't want to be an advocate of one meter versus another. Okay, I think there are lots of weird glucometers in the market, yeah, and I think this will become a higher risk as we get more Chinese things. And so there are some established very good glucometers that are made by big known companies, okay, and I won't mention the companies. But one of the ways to do it is take your glucometer, if you're going to a hospital and you have diabetes, and check it with the hospital meters and check how they correlate. Also, the other way to do it is get a blood test done, you know, like a plasma, the way we check normal blood, and compare it with your glucometer. So if you're getting very wide variations, that's a sign that the glucometer is not very good. And glucometers that give errors or are not giving you readings that are consistent with, let's say, your 3-month testing, you question again. So I wouldn't talk about the companies, but do your homework.
All right, I've seen Faith teachers ask the same question twice. Then it's a very important question. If someone was diagnosed when 26 years old, is it type 2 or type 1?
Yeah, Faith, that now is our work to find out for you. And remember, we talked about the groups that are in between. So now, Faith, we have individuals who are 20 years who have type 2 because they're obese, okay? And we have some older people in their 60s we find to have type 1. They're very hard to treat. Then if you check the antibodies, actually they are positive for antibodies that are related to type 1. So you can actually, it's not that clear-cut 1 or 2. And usually the people who are between, let me say, late 20s to 40 can fall into those groups where they don't behave in a classical pattern. So they are not behaving classically like type 1, but yet they are not overweight and obese and have the pattern of type 2. And that's where I think a good physician and doctor comes in to just discuss with you and help you with your management and individualize it.
Okay, this is a long conversation. We cannot finish in 1 hour. I want to ask the last question, Nekesa Tabi. Can diabetes affect the dental formula? My dad is on insulin and pressure medications, has been going for dental cleaning, but it has reached a point some dentists tell him that remove some teeth.
Okay.
comment on.
So good question. And remember, in the allied healthcare workers, not allied, but important other people we must see as with diabetes, is diabetes predisposes to gum disease. So just the same way we check our eyes with diabetes once a year, cleaning of teeth before you get cavities or abnormalities with the gums is part of annual checkups. So yes, diabetes does affect the oral cavity more than we like to know, and it's better to have those checks before you have extensive disease. And it is not due to the insulin, and it is not due to the tablets.
Thank you, Prof, for educating us. You've empowered us. We are very excited. We at least know what to do and what not to do, and what to think and not what to think, because sometimes you may be affected by diabetes, and you may be with a family member who has diabetes. So it is good to have information like this. We appreciate you. Thank you very much. Over to you, Grace.
Thank you.
Grace, are you there? Grace? Ah, okay. Looks like...
Richard,
yeah.
the meeting.
Sorry? What she said? All right. You've been given knowledge that empowers you to be a person who creates impact, whether you have diabetes or you do not have diabetes. You know what you should do. Prof, thank you very much. Those who have attended, thank you very much for turning up in large numbers. Thank you very much for sharing the flyer. We've been enlightened. Very well. Now it's time for us to thank Prof using your favorite emoji, whether you are sad, whether you're grieving. Kindly appreciate Daktari, because gratitude is what will make her to come back and tell us more, because this is a conversation that is intense, which we need even to go to a hotel and talk about it the whole day. Please select your best emoji and appreciate Professor Nancy Kunyiha for having created time so that we can be able to become more empowered. Jacinta, if you are there, you can share the link to Atara Solutions for those people who are not members, to say, because this flyer went very far, that people could wish to join Atara Solutions for future engagements. So Jacinta, you can share the link to Atara Solutions.
Thank you, Richard. And
thank you very much.
And more engagements in time to come. Thank you to an engaged audience and for people staying on this late. Yeah, thank you.
Thank you very much, and may God bless the night of everyone. Make sure you do not eat like kings tonight and queens. Okay. And always, supposing somebody wants to reach you, Daktari, what will somebody do? Could you wish to?
I can. What do you want me to do? Give my telephone.
Your telephone.
Email? I don't know how you will share it. Maybe Grace will find a way. I'm on 0733 743 261. You can send me a message, or maybe Grace can share a contact. Yeah.
Exactly. Thank you.
Yeah. Thank you so much.
Great. Good night, everybody.
Good night. Thank you. Thank you.
Asanteni sana.
Good night. Thank you, Grace.